Good morning, guys. Do a quick video for you here. This is week 2, day 3, and Monday's a holiday. I remember the holiday day. So hope everybody's doing well. Again, if you don't understand anything, send me a text about anything. Okay, I want to go over a few points here on some of the unintentional torts that can happen in a hospital, specifically in an OR, and give a little bit more detail to some of the things that were in the book. So, hope you have a notepad and a pencil. Okay, patient ID. You will often hear the patient say, "I've done this 20 times already today." That is, when we go to transport them, anytime a patient is passed from one caregiver to another, the ID process occurs. Where I worked, it was always, being in surgery, it was always 3 pieces of information: name, date of birth, and what are you having done today? Where is it? Right arm, left arm, right leg, left leg, whatever. And if the patient says, "I've already done this 20 times per day," that means everybody's doing their jobs. If they say that's the first time they've been asked that, then maybe the caregivers are not going to the trouble of doing this. It didn't used to be done all the time, but it's pretty much standard practice now when there's a transfer of a patient from one caregiver to another, and it eliminates the possibility of errors, because you will, in a rare instance, have patients with the same first and last name, maybe even there for the same surgery on the same day in different rooms. That's why we do this. We never lose our focus. We always do what we're taught. This is a procedure. Do it. Never have a problem. But that's when you'll be transporting patients occasionally. You go over leave the OR, go to the hospital. Maybe this patient's been in overnight or something. You'll go transport them back to the OR. So that's when they'll be transferred to your care from the nursing floor, and so they will be patient ID will need to occur. So I don't know if these are in any order or not. I'm just going to go through them. Timeout. Timeout is a procedure, of course, when everything stops. Everybody in the OR, we're right at the point of being ready to cut skin, and that's when most ORs will do the timeout. Everything's been set up, draped, doctors in the room, gowned and gloved. The lights down. The lights on the surgical site. We're ready to go. Then is when it's usually the nurse, the circulator, says, "Okay, y'all ready to do timeout." If, for instance, they forget, well, that's supposed to happen, so you're going to say, before we cut skin, before you pass the scalpel, you're going to go, "Are we going to do a timeout?" This, again, is a safety procedure. Everybody stops what they're doing. I don't care who you are. Everybody stops what they're doing, including the surgeon. Everybody is silent, including the surgeon. And the circulator holds up the patient chart and reads off the name, date of birth, the procedure that is about to happen, the site where it's about to happen, and allergies. Anything pertinent to this particular patient that makes this one different. That's what the timeout is for. Everybody agrees. The surgeon agrees. We're good to go. Another procedure that, if followed properly, prevents wrong site surgeries. And you're gonna find out from some of your assignment today the problems with how wrong site surgeries even happen when you look into some of these lawsuits that you've been assigned to. Okay, count. We count sharps and we count soft goods. More specifically, that would be needles, scalpel blades, sutures, sponges, all the different sponges we have. Also, instruments are counted in cases where we go into the abdomen. We're not going to count instruments on a case where the incision is real small or on laparoscopic cases. So when there's a belly incision, there's a big incision where things can get lost, then you have to count instruments. But this prevents what we call retained foreign objects. The count occurs in the beginning before the surgery takes place, before the skin is cut, to establish a baseline count. Everything is counted each time a cavity is closed, and an organ is closed, the abdominal cavity is closed, the skin is closed. Each time there's a count, and that must match what we counted at the baseline. That final count is all important, because if it doesn't add up, then it's either in the floor, it's whatever it is, a suture, needle, whatever it is, it's in the floor, it's our sponge, it's hidden underneath something. When we have to find it, the more organized we are, the less problem you have. You keep up with this stuff during the case, you don't have any problem at the end of the case. That's when you have to focus, you have to know what you're supposed to do, and you have to be on your game. Otherwise, it's going to be another 30-40 minutes trying to look for these things. You may have to call, x-ray may have to be called in to x-ray the patient while they're on the table before the surgeon puts in the last suture. I've seen people have to dig through the trash in the room, looking to see if a sponge got stuck to something and was thrown away. This just goes to show you, if you're more organized during the case, you're going to be good. 99 times out of 100. You're disorganized, you don't pay attention, you're going to have problems. The OR is not going to watch you around for too long if it happens very often. Very, very, very serious. A retained foreign object in a patient can cause infection. It can cause all kinds of adhesion. The body tissue say, hey, what is that? That's not supposed to be in me. Then there's adhesions, the scar tissue, and all that kind of stuff. But infection is the real danger, because that can lead to loss of a limb, can lead to an attack of sepsis. It's just, the liability is incredible. But a simple count procedure. Patient burns. Patient burns, they come from the electrocautery that we use. And here again, this is medicine. The electrocautery is also called the cautery. It's called the ESU for electrosurgical unit. It's called the Bovie. All these names, B-O-V-I-E, Bovie. But patients can get burned if that cautery instrument is not properly secured and taken care of. It has a button on it that activates it. So if that, and there's usually a plastic sleeve that thing goes back into that protects it. So we'll go over more of this in lab. Fall errors. Falls can occur when patients are transferred from one bed to another, from the stretcher to the OR table, from the OR table back to the stretcher. Often you'll go to the hospital, like I said, to get a patient. You won't bring the big hospital bed over. You take a stretcher over, transfer that patient from the hospital bed to the stretcher, all the way back to the OR, and then from the stretcher to the OR table. So there's a lot of transfers that go on. We're going to practice that technique in the lab, but the stretcher will have bed rails on it. Those rails always up. Whenever there's a patient on that stretcher, the bed rails are up. That way the patient cannot roll off or fall off when they're being transported. That's something that can happen. But that's what we mean by falls, when they're going from, and these stretchers are always locked in place when they're moved up to a bed or the OR table, or the wheels are locked so the stretcher can't move. And you get used to testing the stretcher, especially if you're coming in a room brand new, they just called you in to help transfer. You go in, you grab a stretcher and give it a shove, it's locked in place. I don't care what, if I haven't been in there to see somebody else lock it, I'm making sure it's locked before I touch anything. Just a habit. Habits you get into that prevent problems. Let's see, a large patient. For every patient that's transferred in the OR from stretcher to OR table, it's a minimum of 4 people. I think somebody put 2. There's no way 2 people can move a patient. You got to realize these patients are sedated. Most of the time they are nothing but dead weight. And if you've ever moved a human being that is dead weight, you'll see what I'm talking about. when they can't help you at all, and they're just totally out of it for whatever reason, they are totally dead weight. You have to move every pound that they have. The larger they are, the harder that gets. But the minimum number of people required to transfer is 4. Somebody at the head, somebody at the feet, and a person on each side. The larger the patient gets, you'll need 2 people on each side, the head and the feet, and that'll be 6. Sometimes we've gone up to 8. Some of you said on one of the questions, there are more Olympic athletes having surgery than large patients, obese patients. So you need to put some thought into these things. How many Olympic athletes are there? How many obese people are there? So you start looking at numbers like that, there's no way we're doing more surgeries on Olympic athletes than we're doing on the obese patient. Obese patients have heart problems, they have orthopedic problems, they have circulation problems, they have gastric problems, they have lung problems, they have all kinds of problems. Many, many, many more surgeries on obese patients than Olympic athletes. Some of you need to, this was a little bit tricky question. I want to see how you think. Some of you think, and a lot of you missed that one. So let's you can research this stuff. You can research it on the internet. Get the answers to questions like this. Don't ever. Sometimes there's a lot of stuff you don't know. I hate to tell you that, but there's a lot of stuff you don't know. A lot of stuff I don't know. I still got to look it up. Get a good source. Let's see. Drugs added to the field. That's a major process that we do with the circulator. Drugs are the way. Anytime, and some of you missed this on another question. Anytime if you're scrubbed in, you're in a sterile situation. If somebody's going to add something to your sterile field, they have to be non-sterile in order to do it, because when they get that item off the shelf, it's not sterile, right? So you can't, as a sterile person, scrubbed in, gowned and gloved and everything, go over and get something out of the cabinet and add it to your field. You can't do that. A non-sterile person, which is the circulator, or another tech who's not scrubbed in, has to do that for you. They open it up, and there's a process in how they deliver it to us so that we don't touch each other, we don't contaminate, we don't get contaminated. There's ways, everything made for surgical use is made so that it can be opened and presented to the sterile, to the surgical tech, so that they can retrieve it without touching anything. All that's been thought through. But drugs added to the field, we'll go over that. The name of the drug, the concentration of the drug, the expiration date of the drug, those are all confirmed between the circulator and the surgical tech, and they're also usually stated again by the surgical tech when they're presenting these to the surgeon to use. Power equipment on the field. That was a poorly worded question from yesterday. Power equipment, it is the responsibility of the hospital to make sure that stuff is working. But here was the gist of the question was this. You're scrubbed in. You've opened, you or someone else has opened some power equipment onto your field. You always test it before you give it to the surgeon. There'll be some power source, either to hook it up to or the battery pack. You always squeeze the trigger and test it before you give it to your surgeon. Don't ever give your surgeon something that is supposed to work unless you tested it first. Big, big rule of thumb. Think about that surgeon who is ready, has dissected, for an hour. They've done everything they need to do to get where they're going. And then you give them something that they need to use right then, and it doesn't work. You didn't test it? Ooh. Don't want to be there. You want to be zoomed out of there. Beam me out, Scotty. That's one of those deals. Infection control, lastly, is an unintentional tort. Hospitals are worried about these lawsuits. These lawsuits are major. Infection control. That's the reason I have this added to that Bureau of Labor Statistics job description. I could not believe it wasn't on there. I mean, it's incredible. Absolutely incredible. The misinformation and the lack of communication about what it is we do in the OR. So there's always going to be an educational process you're going to find about what we do, because patients are always pretty much sedated or asleep. When we're in the room doing our thing, the surgeon just kind of pops in and does his thing, and we've set all this up. We're passing it, we're breaking it all down. The circulator's helping. So it's kind of but the circulator's a nurse, and everybody thinks that's all there are in hospitals are doctors and nurses. But that's definitely not true. And we know that. So anyway, I'll wrap this up. It's been about 16 minutes. Any questions on anything, let me know. We'll have a quiz tomorrow, as usual. Good luck. And this will probably be my last video until next week. Okay, so have a good holiday weekend, and I'm sure you can find something to do. So anyway, might include a little study. Okay, be safe.